our next speaker is Dr. Yaseen Khan. He is a South African medical doctor and technology entrepreneur. He is the CEO and co-founder of EM Guidance, which stands for Essential Medical Guidance, which is the largest digital platform used by healthcare professionals in South Africa. It is large. There's like thousands and thousands of users. EM Guidance provides locally relevant clinical decision support, educational and prescribing solutions across the healthcare ecosystem and serves as an official mobile platform for the South African National Department of Health Standard Treatment Guidelines. EMG serves 130,000 healthcare professionals with localized clinical decision support, and the platform has been governmentally mandated for use in all pharmacies nationwide. As the leader of a cutting-edge clinical science and data platform, Dr. Khan is pioneering AI-enhanced clinical decision-making tailored to the South African healthcare context. He holds a medical degree and a master's in clinical epidemiology from the University of Stellenbosch, with a thesis focus on evaluation of decision support technology in local hospitals. He has also practiced as a GP and emergency care doctor and holds a diploma in primary emergency care with the College of Medicine of South Africa. So we'd like to welcome Dr. Yaseen Khan, who is going to be talking about AI in the GP consult, decision support without losing clinical judgment. Thank you so much and welcome, Dr. Khan.
Thank you very much for your audience today. And Tasneem, thanks for the introduction. As Tasneem mentioned, I represent a platform called EM Guidance, which deals very much with South African clinician decision support. And as a result, we think... I'll keep talking. As a result, we think very deeply about the clinician in the South African practice environment. The GP, the physician, and more the pharmacist, the nurse as well. But we think about the clinician and we think about the technology they use, and more the use of AI, particularly for decision making. AI has many uses. It can create all sorts of efficiencies in practice, but fundamentally we think about it from the perspective of guiding a healthcare professional in making a better clinical decision. And thirdly, we think about it with respect to the overall South African healthcare ecosystem, and particularly primary care clinicians and GPs being very much the drivers of a number, if not the large majority, of health system outcomes. And so the GP and the primary care setting and optimizing that setting through technology, and particularly with AI, becomes not only something that's important for us as GPs and for us as medical professionals, but has kind of longer term and long-standing implications for health system outcomes. So as EM Guidance, and maybe let me just ask you a few questions. How many practicing GPs are there or doctors are there in the audience? Okay, that's a good number. Can I ask how many EM Guidance users? That's good to hear. That's good to hear. Can I ask you, how many of you are actively using AI-driven chat interfaces in practice for decisions? So to put in a case query, patient information, and getting answers back. And it's okay, we won't go beyond this, but can I ask, show of hands, how many have started to use those interfaces? It's good, probably about half. And can I ask how many double check it? Okay, that's very good to see. And it spells of our own understanding that these things need double checking, they need a safety check, and we are still working around building trust with AI. So, because EM Guidance has become so exceptionally well used and pervasively used around the country, there's a clinical search, a guideline, a medicine, a clinical query every second of the day now in most practices, hospitals, facilities. We've been really asking ourselves deeply the question, how do we ensure the optimal balance between AI systems, AI decision systems on the one hand, and clinician empowerment on the other hand, and making sure that we have the most optimized balance between this human and machine combination within the clinical practice. And so the starting point for that is really unpacking the complexity of a clinical consult and really asking ourselves from a tiered perspective, what is it really made out of, and where do human capacities prevail and where are machine capacities starting to creep in. And the first tier is really about the patient and the narrative, and the history, and the collection and curation of data from your patient. And that part is incredibly messy. It's unstructured, it's messy, it may not actually be complete. And the human skill there to entice and bring out what are the real critical historical factors becomes quite important. And then you've got your clinical reasoning element, which is very structured. We are obviously trained to do that. But critically, it's not an area of certainty. Clinical reasoning for certain cases can be certain, but fundamentally, as clinical cases become more and more complex, we get into realms of uncertainty and, as they say, probabilism. And thirdly, we all work in different contexts, whether we work in the state, whether we work in the private sector, whether we're seeing patients on different medical aids, whether we see patients on, cash patients, whether we see patients that, only want to deal with a specific aspect of their health. Ultimately, constraints are very real for us as medical professionals. So the challenge is what you have is you have the introduction of machine, which on the far right is optimized for one, ideal medicine and scale. It's optimized for speed and confidence. It's optimized for recall. It's not really optimized for the uncertainties and ambiguities that we experience from a practice perspective. The human being, clinician on the other hand, is optimized for context. Is optimized for eliciting the right symptoms, understanding the right constraints, understanding the patient's economic limitations, the scheme's economic limitations, social factors around the patient. But very critically, a human being and a clinician is designed to actually be fundamentally accountable. There's risk on your end. And in addition, we are designed to operate and steer towards managing uncertainty. These global frontier models, as they call them, are actually motivated. They're digitally motivated to find an answer. They've got to find an answer because that's how they achieve scale. And so that subtle difference between being optimized for managing uncertainty and being unclear and doing more and seeking more and more context, it's a very key difference between the human being and the machine. So uncertainty awareness, accountability, judgment, and context are things that need to be maximized on the human side. But naturally, what we need to do is leverage machine capability. So critically, clinical judgment is not replaced by AI. It's stress tested by it. It means that all the more in this age, clinical judgment, in clinical context, and being a good doctor and a good clinician is now more than ever much, much, much more important. And optimizing your interface with AI and machine learning, with machines and as well as machine-driven decision support becomes critical. Because as mentioned, the machine can fail, and it fails spectacularly in areas of ambiguity, constraints, uncertainty. And very practically, if there are very specific local parameters, drug availability, guideline availability, clinician logistical, patient logistical factors, can they actually get to the investigation the next day? What are the social factors at home? Does the patient's medical aid actually cover the condition? do South African guidelines and protocols dictate that with our local epidemiology and burden of disease, we do those things? There's major international bias that doesn't effectively contextualize, among all the other uncertainty factors that I mentioned. So I started with sort of a general philosophical description of man versus machine, woman versus machine, and the GP and context environment. But we spent quite a bit of time as EM guidance, and maybe some of you have received our surveys and may have even participated in some of our user research. But, you know, we spend an incredible amount of time in practices with clinicians of all ages and profiles. And our goal is really to understand what's actually happening on the ground. What's actually happening in this day and age with respect to the use of AI, the adoption of AI, how the users and healthcare professionals would like to see EM guidance evolve. What is the actual need in terms of effectively using AI on the ground in the South African primary care practice environment? And there's a whole process behind this where, you know, we do scores of interviews and we try and rank the themes that come up commonly. And I'm going to zone into just a few of them. Apologies, you can't see some of the text. And I'll skip between this and some of the quotes, right? If you read what's on the screen, right, it's from a GP in Gauteng. We're all still supposed to be using our brains. We're supposed to be making decisions smartly, supposed to be using higher reasoning. We're not just blindly following something because somebody told us it's safe. And this sentiment and theme is coming over and over and over again. That it feels like it's smarter than me. I'm abdicating my reasoning. I'm abdicating my intelligence. And my patient is going to ChatGPT before they come to me. And so what does this really mean for me? I'm supposed to be doing this. And so there's this sense of mistrust and there's this sense of distancing that's coming through. And then there's a frank sense of, as many of you have attested, you check, you double check. I don't chat necessarily for medical purposes. I feel like it's still a search engine that patients will use. Although I'm sure chat will actually give me the right answer, to be honest, but I feel like it's not trustworthy and I feel like it's not evidence-based. And I think that probably rings true with many of you that said you need to double check it. And this was an interesting one, and the sentiment came through very strongly as well. I prefer to have something that acts like a colleague, a discussion colleague, than something that sort of instructively gives me an answer, like a co-pilot or coach, as opposed to something that is very deterministic and tells me, I've done everything, I've checked everything, and I've got the answer. I'd be able to say this is a really difficult case that I'm dealing with. What differentials, perhaps? Perhaps I missed something. What are the extra investigations? What should I be looking at? So structured support, like inline expert coaching within the case that you're dealing with. And this theme, this sort of theme of having something there that's there if I need it as an added sort of clinical intelligence, but not something that is running the show. I'm fundamentally running the show. And so three key themes came through from our user research, which is, one, I need to trust the system. And trust came through on a number of fronts. I need to trust that every last recommendation came from an evidence source. I need to trust that it aligns to all local regulation and policy. I need to trust that whatever it does with patient information, it doesn't breach POPIA laws, privacy laws, etc. So trust, fundamental factor. Context. If an AI system is going to be used in my practice, I need to be able to feed it with as much context as possible. If it doesn't know the full or relevant detail of the history that the patient is giving, it doesn't know where I'm practicing, doesn't know what medical aid the patient is on, doesn't know some of the constraints that it doesn't have any consideration for local guidelines, protocols, then I don't believe that it has enough context for me to trust it. And lastly, per the last quote, the theme that came through was, I really need this thing to be a source of support rather than a replacement. And it mustn't sort of allow me to abdicate judgment. I need to do my own clinical reasoning, and I need to have a source of support on the side. And we took all of this in, and in our own sort of design and system thinking, and really thinking through what are the, if you take the human-machine interface in the clinical environment, if you break it down, take all those inputs and you say, break it down to what are the actual failure points. What are the failure points that would cause a negative outcome in terms of the clinician-patient interface and clinical outcomes? So number one, false confidence, mainly due to lack of context. If you go to frontier models, the hallucination rates are still high, too high for clinical practice. Some range anywhere between 5, 10, 30%. And why is that? It's because, as I mentioned earlier, they are optimized. They're optimized to give you an answer. So they want to make sure they give you an answer, even if the answer is wrong. Context loss, as mentioned, there's just so many important things about the clinical case that the system doesn't know. Idealism versus reality. So the system gives you what is generic medical evidence and doesn't really speak to the South African epidemiologic reality, South African medicines, guidelines, rules, compliance reality, and cognitive offloading, which is we need to absolutely ensure that clinicians, as they use the system, keep maximally thinking as opposed to sort of, offloading the intelligence to the machine and then just randomly accepting. And then lastly, fragmentation. What we mean by fragmentation is you'd often go to ChatGPT or Google and it's a completely separate system. And you may be using EMRs, you may be using a digital prescription system. And so that system doesn't have some key data from the other systems and you've got to replicate context. And so what we're doing is taking all these themes in and constructing on the basis of EM guidance being used as quite a regular interface in the South African environment, really asking ourselves, what would a South Africanized, contextual, safe and assured clinical AI look like and how would it be implemented in a South African practice? And the shift, the general strategic shift is we need augmented clinical judgment, and we must shift from being an answer engine, which most frontier models are designed to do, to some form of cognitive support layer. And so number one, an AI support system needs to provide an expanded set of possibilities, and it mustn't narrow a diagnosis or a treatment too quickly. It must provide structured guidance to your thinking. It must be able to surface relevant constraints to your treatment, and it must support decisions and not make them for you. And so that brings us to the sort of closing phase, which is sort of what we've developed, what we're releasing, and the discussions that we're having and early tests that we're having with the likes of yourselves as South African healthcare professionals. Number one, it is a contextual AI. It's an AI that speaks to the local system. Two, it's actually embedded into workflow systems. So embedded into e-scripting, embedded into electronic medical records, embedded into discharge systems, referral systems. Thirdly, it is definitely a decision support, not generating an answer. It's very much a co-pilot. And thirdly, we're integrating as much context, as much patient context, and as much ecosystem awareness as possible. So what are some of the public health challenges, antimicrobial resistance issues, vaccine drives, all the sort of nationally driven challenges that ought to be understood at a practice level. How do we begin to integrate the ecosystem and public health into the AI system? And the move is, of course, from generic answers to safe contextual decisions. So given that this is the current map of EM guidance, and as many of you know, you search it for medicines, for clinical content. Some of you use it on the web, some of you use it on the mobile. And as you can see, it's used in virtually every quarter of the health system. There's a search every second of the day. And over the past decade, there have been something like 100 million clinical interactions with the platform. So over the next couple of weeks, the platform is going to change. And apologies, you can't see the detail here, but this is the internal sort of EM guidance AI chat interface that you'll see shortly. So this is the first sort of early preview of it. And there are a couple of key notices. We obviously can't release it yet. It's still undergoing testing and safety and accuracy. But the first key thing is that the way we're designing the system is very much for context. So it's not only for GPs, it will be for pharmacists, it will be for nurses, it will be for clinical associates, it will be for medical students, it will be for specialists, it will be for nurses. And depending on who's asking the question and where they're asking the question and what question they're asking, there'll be a different level of answer, just given the vast kind of clinical decision support needs and the scope of practice requirements and the legal scope of practice requirements for every type of healthcare professional across South Africa. Situation. Inbuilt, are you in a GP practice? Are you in the public sector? Are you in the private sector? Are you an EC? Are you making a decision in a theater, in a hospital, in a ward, etc.? And then very importantly at the bottom, probably the most critical factor, what we've done is we've established, given that EM guidance has an aggregate set of clinical guidelines provided by an academic network around the country, we are defining and managing an AI-ready clinical knowledge base for South Africa. So, national standard treatment guidelines, professional society guidelines, medical scheme content, logistical care coordination, facility information, drug information, antimicrobial resistance information, public health information. That's overseen by a set of university academics and managed as a defined, human-approved, local expert-approved knowledge base, with the relevant university representation, as well as a sort of clear governance and transparent governance process. And what that does is the AI system reads, at least for the first launch, only from approved knowledge sources. So that means any question you put into EM guidance, guidance AI, we know that it's an 100% explicitly approved, highly contextual local guideline, protocol, medicine recommendation, scheme recommendation, you name it, kept up to date. And we can actually, in the engineering, make sure that the AI doesn't read the general internet. So that already on its own is a massive step, because it's a way of using AI with 100% assurance in the South African environment. And by locking down the AI to a certain knowledge base, we can reduce, and there's obviously some other tech involved, but we essentially reduce hallucinations to zero. But partly the way we achieve that as well is the first use will be relatively limited, in the sense that we are very happy to say we don't want to give you an answer. If it's a complex clinical case and there's a diagnostic complexity that we can't give a certain level of assurance on, we'll say, well, for this answer, not yet. Because we're not as motivated as the international companies to always give an answer, because what we are optimizing for is safety, trust, and something that you can actually provide to your patient with 100% certainty from a medical legal perspective, from a safety perspective. Still relying on you to make the clinical reasoning and judgment, but having a kind of added support system that, you know, allows you to move. The system will be far more open and questioning to you than you would have experienced before. It's going to ask you more and more context. And there will also be an opportunity to integrate directly into your electronic health record systems, laboratory results, etc., for a particular patient. So you will, as we go along, you can use the interface as a clinical assistant tied to kind of South African knowledge source. Secondly, what I've shown you is the sort of standalone system. We're dealing with the approach of embedding. So as you move through, you make your record in your electronic medical record or your digital scribe, you'll start seeing EM guidance inside other systems. You'll start to see it inside scribes, inside hospital systems. And that's those same sort of recommended and approved protocols you'll start finding popping up at relevant points. And on prescriptions and on referral systems, pathology systems, you'll find relevant clinical scheme-related, what are really recommendations. You can always override them. You can advance without doing them, because fundamentally what we believe is that the clinician is fundamentally autonomous, always makes the judgment. And just a bit about sort of what's under the hood. So what you can see is there's this knowledge base that has medicines information, protocols, guidelines, care coordination information. So what we mean by that is referral services, destination services, facility opening times, specialist networks, every possible destination that you can send your patient to, managing that very appropriately within the platform, integrating medical scheme information, and pulling all this into a system. And without going into too much technical detail, there's a number of safety guardrails, a number of privacy de-identification techniques that are done. And everything is fully audited and reproducible, which is something you can't do internationally as well when using most foreign international systems. So you can go back, you can look at the record, you can get an audit trail. This becomes important if there's ever a medical legal issue down the line. So all these little safety nets, the audits, what we're really taking is the HPCSA guidelines and SAPRA guidance on the matter and trying to design a system that actually makes it 100% safe and workable within the South African environment. And then many of you will see that we've already started plugging in and integrating into some of the practice systems that you use. So as you can see on the right-hand side, some of the bigger practice systems will have certain EM guidance modules already plugged in. And then importantly, there's some major governmental and stakeholder support for the project. So what's important is that the Gates Foundation has provided significant support to EM guidance to expand this, what is really an AI safety initiative for South African healthcare. And so the expansion of this AI-ready clinical knowledge base and this ability to ensure that AI recommendations provided in other systems are safe is a major national project and essentially designed to support safety within other and third-party workflow systems, not only EM guidance. And then a couple of important ones. EM guidance obviously integrates national standard treatment guidelines, but most importantly for the private GPs in the room and for some of the specialists as well, navigating medical scheme formularies and which drugs have copay and which hospitals are on the network and which benefits can you access for your patient, where do you refer them to such that you don't deplete their benefits and they don't have copays and that they can actually utilize all the benefits on a chronic care program. That information we know as GPs and specialists locally is extremely difficult to come by. And EM Guidance has managed to enter a memorandum of understanding and a contract with the Council for Medical Schemes to now work towards integrating that and serving that through a very simple interface to medical professionals. So the idea is you would be able to ask the AI any medical aid question, and it will give you guidance on what exactly you can do maximally on that particular medical aid to enhance the benefit of your patient. That's something that's been extremely difficult to do. You'd have to go into multiple different medical scheme portals to make an effective decision, and something that at least from a governmental perspective and a regulator perspective, there's quite a bit of support on now, which is fantastic. And so in closing, I think perhaps just a closing note on what all of this means if we get it right and if we do this at a national scale. South Africa, from an overall health system perspective, has an enormous challenge, like many other health systems around the world. But one of our biggest ways of articulating the challenge is that it is an economic challenge. Healthcare costs are completely running away. Premiums are rising 10% plus every year. We are getting less and less from medical aids. And what's happening is that less and less people are joining medical aids. Can't afford it. The medical aid member base is not growing. More people have to be paying out of pocket. And it's getting to quite a critical point such that it impacts the solvency of many medical aids. The entire private healthcare system is at risk because we can't seem to really get control of runaway healthcare costs. And what's the biggest challenge with healthcare costs? More than half of healthcare costs in South Africa are hospital-based. Somewhere upwards of 20% are for specialist and downstream services. And 5%, less than 5% from the Council for Medical Schemes report is allocated to primary care services, GP services, etc. Now, there's something very wrong with that equation overall for South African healthcare. The first key problem is that we should be spending more, much more earlier on in the chain, right? We should have better funded, better structured, more capable primary care and preventative care, because then we can prevent downstream consequences and change the equation in that. So the more our GPs, the more our primary care clinicians and frontline clinicians do better screening and disease identification, the more they better manage chronic disease, the more they are able to identify high-risk individuals and manage them early on. If we simply followed oncology screening guidelines and did colonoscopies and mammograms when we should, and we tested for cardiovascular conditions as and when we should, we can massively change this equation. The challenge is that as GPs, as primary care, we are overwhelmed, we are busy, mostly underfunded. And so what we are looking at is how we leverage AI, particularly in the GP and primary care clinical practice, to really, really strengthen the preventative and early disease management capabilities of primary care practitioners around the country. And the state is interested in this, the medical schemes are interested in this, and the GPs primarily are interested in this, because what this means is that we are really strengthening primary healthcare to eventually change the spend equation and turn it completely around. And some of the examples that we're considering and thinking about is a GP and a clinician should be fundamentally supported and prompted to undertake preventative action, to undertake screening action, and to manage disease better early on. So what would that and what could that mean for AI? So we take the EM guidance chat interface and the right kind of prompts and targeted prompts to say, hey, there are certain patients that you see that are on medical aids. The medical aids actually want to pay for certain screening investigations. Patient so-and-so needs a mammogram, patient so-and-so needs a colonoscopy. You need to check the HbA1c of patient so-and-so. Those kind of like very active prompts and engaging medical professionals with potential preventative actions that could be funded and supported is one angle. And there are a number of others where within workflows, and these are obviously just concepts here, within workflows, that a genuinely smart system is not only looking at the patients that are in front of you. A genuinely smart clinical AI system is actually thinking about the country and the ecosystem as a whole. And so it's really trying to prompt and make you aware and trying to guide you towards becoming the best clinician, not only for the individual patient, but across board. So we're a little bit away from that. We're naturally going to be launching something in the next couple of weeks, so you can, this was sort of my last point, enhanced screening, chronic disease management, better optimization of chronic care benefits, public health campaigns, targeted high-risk reminders. These are some of the things you can start expecting within EM guidance. And again, you make the judgment as the clinician. You choose when to use something, when not to use something. But a proactive, preemptive system. And so in closing, thank you very much. Please look at your EM guidance admin platform over the next couple of weeks. You'll start seeing this. We're going to stage it very slowly. It'll be very limited at first. We invite feedback. But ultimately, our belief is that we can build whatever we want. It's really about who's driving. We can build the plane. It's really about who's piloting it. And so we want to make absolutely sure that, it's a system designed for safety, for context, and for trust. And look forward to engaging all of you as we go on that journey. Thank you very much.
Thank you so much. We have time for a few questions. Are there any questions? No questions. I'm very surprised. Oh, we have one over there. Somebody? Oh, you have a question.
Hi, Dr. Khan. It's not so much a question, but a comment. I use EM guidance a lot. I just want to say I'm actually starstruck right now. Thank you so much for that app. It is amazing. I don't know why the rest of us didn't think of it. As far as what you were saying about, trying to enhance and getting the primary healthcare system, I am a passionate believer in that because I work in the hospital setting, especially in the state, and the burden is incredible. So obviously, where we're going wrong is at the primary level because we are the ones that are getting the brunt of what's not happening at the primary level. So yes, I totally believe in that and I support you 100%. Thank you very much.
Thank you for that. I mean, it's so true that at the primary care level, this is where the issue is. And so many systems focus on, we start with complexity because complexity sometimes is sexy, but the real problems exist at the ground floor. We're not screening, we're not preventing, we're not managing chronic disease properly, given all the burdens we have. And so if we can leverage AI to solve the common things that are causing big problems, we can actually make much bigger impact. And the state is obviously a key area as well.
Yeah, thank you very much for the presentation. I just want to know, is the app available at the moment?
Yes, EM Guidance is available. You can go to the website or the App Store. You've got to be if you've got the registered healthcare professional details, either doctor, nurse, pharmacist, any regulated registry council, then you will be able to get access through a verification process in the platform.
No, I'm already part of EM. I'm talking about this particular app.
Oh, sorry.
For the AI.
The AI. No. So it's in internal testing.
Okay.
So there are a few users that are using it, but we are evaluating safety and running evaluations and research at the moment. But in the next couple of weeks, there'll be a first version live in the app.
Sure.
Yeah.
Thank you.
Thank you for the presentation. Just a quick one. Are there any risk of over-reliance on AI, especially for GPs? And to follow up on that, also in terms of medical-legal challenges, what can you maybe say about that?
Yeah. So we think over-reliance is probably the key risk. And the question about maintaining autonomy and judgment is really the primary factor here. So never simply accept. Always understand that it can be wrong. Throw it out, if needed. That sentiment comes through strongly also in the guidelines. So I think there's a talk later on the HPCSA guidelines. The theme is very clear that the clinician takes responsibility. And the difficulty with that is if you're going to take responsibility, then a couple of things follow from that. So you have to be able to explain to the patient how you got the answer. You have to be able to reproduce the answer. Right? So you've got to put the same question back and get an answer. And you've got to have an audit trail. So if need be down the line, you can actually extract that answer. So the regulations are sort of very clearly saying that be careful about over-reliance and ensure that you as the clinician ultimately take autonomy because you are ultimately at risk. And so medico-legally, if you're doing those things, and hence you can see what we're trying to do is provide practitioners with a system that the record, the clarity, the lack of hallucinations, the audit trail, all those things are there so that you still make the judgment, but if you need that recourse, the system is there for you. But the medico-legal risk will remain. You as the clinician still take which is why this is such a serious thing.
You were here yesterday when they were talking about SARS. It's the same concept, right? Even if you have an accountant doing your books, at the end of the day, the accountant can be the one at fault, but you are the one who's responsible at the end of the day. It's the same thing, exactly the same thing. One last question?
Thank you for that presentation. It was very enlightening. I'm not South African. I'm Zambian. I practice in Zambia. And you said that this app is only for South African practitioners. So if I practice in Zambia and I put my HPCZ as opposed to HPCSA practicing, it wouldn't work. But would it work? And then if not, I think it would really be beneficial for you to think about maybe spreading to SADC, because I feel like Sub-Saharan Africa, our guidelines tend to be similar.
Yeah.
So that would be something that you'd like to consider.
No, I mean, it's such an important point. I think the key focus for us is to make sure that we make sure that it works well within local and contextual guidelines, the restrictions, compliance, and so that takes quite a bit of work. So just to make it work well for South Africa is what we're focused on. But it's such an important point as well that so many healthcare professionals are working, and I wasn't clear if you're working outside or you're working inside. Okay, from an outside perspective, there's a limited non-AI, limited content version of EM guidance that you can get access to if you are in Zambia, but it's very limited. To your point, we do have the concept and intentions to localize, but then localization means a genuine investment in localization. So what are the local epidemiological factors? What is safe in Zambia may not be 100% safe in South Africa. The drugs are different, the prices are different, the regulations are different. Differential diagnosis, approaches may be different, antimicrobial resistance may be different, etc., etc., etc. And so that localization work becomes important because for each one of those decisions is a patient life. But I mean, thank you. I think as and when we progress, probably not this year, but towards next year, we are thinking about how we start localizing, in other countries. And I think the starting point will definitely be SADC and the neighboring countries because, like you say, they're so similar to South Africa.
The good thing is that you would have gone through this process with South Africa, so when it comes to you, it's like chop, chop, quick, quick. Okay, thank you so much. I think everybody found that really informative, so we really appreciate you coming to speak to us today. We have a little gift as a token of our appreciation.